in palliative medicine. I've been down in Bridgend for a number of years and then was lucky enough to join the City Hospice team in 2016 when I came back to run all the courses from Cardiff University. And it's great to work as part of the community. My background is general practice. I was a GP before, as I keep on saying, falling into palliative care by mistake about sort of, oh gosh, dare I say it, it's nearly 30 years ago now, but I don't feel I've ever really lost my GP roots, and it's lovely to be working in the community. Let me ask Catriona to introduce herself.
So hopefully you can hear me. Excellent. So my name's Catriona. I'm one of the clinical nurse specialists at City Hospice. So I work closely with the GPs around Cardiff to have a support to our patients in the community. And I'm hoping to talk to you today about diagnosing dying in non-malignant disease. I think James is joining us upstairs. I'm not sure if he's showing up yet on the system.
He's not showing up yet, but he will. So we're going to be joined by James Davis.
So he'll pop in and out of the discussion and just raise some other points that hopefully will be quite interesting for us.
I'll just say, Charlotte, you probably know, but Charlotte, do you want to just introduce yourself as well?
You said that just as I took a massive mouthful of crisps. So I'm Charlotte Stevenson, and I'm one of the business development managers at Cardiff University, and we're just responsible for facilitating this kind of webinar. So I'm in the background. If anybody's got any problems or technical issues, just send me a chat.
Wonderful. Thank you, Charlotte. Just to help us know who's in the room, we had a couple of polls before starting. Charlotte, do you want to just launch the polls? I love this expression, launching the polls. In terms of we're just checking to make sure that we're going to pitch this at the right place. So in which setting do you work?
So the polls there, so I'll sort of let you know. I don't know if you can see the results, but could one of you mute yourselves, Kat or Fiona, because the echo is a little bit echoey.
Lovely job.
So we've got about 67% community, 17%.
Fabulous, thank you. So the majority in the community, wonderful, a couple of mixtures and some mainly specialist palliative care. Lovely, thank you. That's just really helpful because it gives us a feel for who everybody is and where we are. And so my last thing before I really do shut up and let Catriona take the floor is just to say, please use the chat to ask any questions or to write any comments or reflections, because at various points through the next hour we'll be looking at the chat and answering questions, and particularly, and there may be one or two points where actually we deliberately say, please write something in the chat about how you feel about this, that or the other. So don't be shy, please use the chat, as that's our main way of interacting, and no question should remain unasked. That's the thing. Thank you, Charlotte. I'll be quiet. It's probably me. No question should remain unasked. If you're thinking about it and asking it, then somebody else probably will be asking the same thing as well. So please feel free. I'm going to hand over to Catriona now. Thanks, Catriona.
Lovely, thank you. Can everyone see the screen? Are we getting the screen now? Yeah, brilliant.
Yeah.
So welcome to our conversation. I think we were going to initially just throw it out if anyone wanted to put anything into the chat to Fiona. What do you personally find challenging in diagnosing dying in patients with non-malignant disease? So it could be anything, but I think it's really nice to get some of those thoughts out there. I know one of the personal things I find difficult is, the uncertainty. People can often present and you think they're end of life, potentially there's a reversible cause, or someone with dementia or even end-stage renal failure. They can be so variable day to day, and it can be very much you go in and see one snapshot and the next day they can look very different, and that can be really difficult, and it can be really challenging for families. Is there anything coming through?
Not as yet. Not as yet. Please add your thoughts. I think, in fact, to add my thoughts immediately as well, is just that I think for me it is also that uncertainty, but for me sometimes it can be managing people with lots of different conditions. So you're weighing up the reversible causes for somebody who might have Parkinson's disease, somebody who might have a bit of diabetes, end stage heart failure. And so it's not just one condition such as cancer, it's lots of different conditions, and it's weighing that up and then combining it with people's priorities. And it's complicated, and it's the sort of thing that actually 2 or 3 minutes is not going to be enough. It's about how we can incorporate this into things. So that's one of my difficulties. And thank you, Gail. So Gail's written explaining the unknown. It can be difficult, and how should this be dealt with? And actually, what is the unknown the same? Well, Sarah's saying there's lots of echoing. I wonder,
No.
is the echoing a bit better?
If one of you
I
mutes
hope.
yourself, I think it should be okay.
So we've got explaining the unknown, which can be difficult, and people's unknown are different. There are different unknowns for different people, aren't there? And the importance of what the unknown is to that person is also different for different people. So we're really starting with a huge sort of web of complexity. Jane's written, talking to the patient and family about end of life. Often non-cancer cancer may not be so prepared for this. And Jane, yes, you're absolutely right. And it's that thing, isn't it, about, death is part of life. We are all going to die, but it doesn't mean that we've necessarily made our plans for it. What can be quite, I've been in 2 houses this morning, and one of them was for somebody who was 91, and just, death was something that was happening to everybody else, even though a number of their friends had died, but it wasn't going to happen to them. It didn't seem to be happening to them. And so it I think can then be quite bewildering as to know where to start, and particularly if you get that sense of urgency when you can see that things are changing, but actually how fast, how quickly, how much do we prepare? And different families will be at different stages of adjustment. We've been in houses where you might have 5 children, for example. Well, it happened to me 3 weeks ago in a house, 5 children, all grown up, all in their 20s and 30s, all at a completely different stage of acceptance of the fact that their elderly mother was likely to die probably in the next few months. But that in itself is an adjustment reaction, and it was very different. I can see, James, I can see that you have joined us as well.
Hello, apologies.
And you're waving there. Fantastic.
Apologies, I'm just proving that I do some work.
Okay.
Sorry,
and so yes, Sarah's saying again, it's difficulty in giving any idea of prognosis. Absolutely, Sarah. Thank you. Thank you for your thoughts. Catriona, I think that gives us a really great, and James, that gives us a really, this is exactly why we've put this session on, and what we're hoping is that over the next sort of 45 minutes or so, we can all just almost develop our own frameworks for how we can make some of these challenges workable with. I think they're all still going to be challenges because our patients are unique and different, every one of them, but it might help us to perhaps get a sort of a framework to feel more confident in managing the challenges. So I shall now mute my microphone and hand over to Catriona.
And there we go. Hopefully we won't have as much echo in there. I hadn't picked up, my microphone was still on. Sorry about that. So thank you so much for your thoughts there. I think it was helpful to have a little look at what level of non-malignancies we're caring for in the community, and what we get in city hospice isn't particularly, I think, relevant to what you're seeing out there. So out in city hospice, about 63% of all of our referrals are cancer related. That's actually changing. So I think slowly over time, we're starting to see more referrals for non-malignant disease. So I believe this data is from 2022. Used to be, it'd be 75-25% split. Now it's nearly 37% of all of our referrals are actually for non-malignant disease. So it is interesting to see that that's improving, because obviously everyone deserves good end-of-life care, no matter what their diagnosis. I don't know why our instruction slides end up there, but we'll move on with it. So obviously the aim of our today's session is to understand the challenges of diagnosing dying in these patients, and maybe look at some of those clinical signs, and have a little chat about symptom management, and maybe think about there's certain conditions and maybe some thoughts about things to consider. And as Fiona has said, please put questions in the chat at any point. She's going to be looking closely at the chat, and we can bring those thoughts to the discussion. So I had a little look at the official statistics from the government website, and interestingly enough, in the top 5 for the all deaths across Wales in 2021, cancer took now it's a main cause of death, not just a sideline comment. But it is interesting that these top 5 here, so ischemic heart disease, COVID-19, dementia, cerebrovascular disease, and the general umbrella term of the chronic lower respiratory diseases accounts for 41% of all deaths in Wales in 2021. Now, of course, as you know, a number of other non-malignant diseases that will also have occurred in Wales in that time, and yet, as you can see, we're only getting 35-37% of referrals to the specialist palliative care team. Across Wales, about 25% of all deaths will be cancer related. So it is really interesting seeing that disparity coming through. Reality is diagnosing dying is hard, and I think this really paints it really clearly. So I'm sure you've seen similar diagrams before. You've got trajectory 1, which is your cancer trajectory. So normally we see people stable for a relatively long time. Then we see a big deterioration, which will happen often in a very short period of time, sometimes days, weeks, sometimes a few months, and then they're receiving that end-of-life care. With organ failure, and that's usually single organ, we see these big dips. So we see someone stable with a baseline that's generally going downhill, but over a big dip, and you return almost to your baseline, then you continue to go downhill, and then you have another big dip as you get these exacerbations, and then they're managed, but you're continually going down, and then you do that last deteriorate. And then, interestingly enough, you get to trajectory 3, which is what I think more often we see in non-malignant disease, is this very uncertain, very slow, gradual decline in people's functions. And I think that's what makes things very hard for not only the dying person, but the people around them, to really recognise that someone's becoming less well over time. And I think it's really important, certainly from a palliative care point of view, we start these conversations very early. And I think it's about not being afraid when you start seeing people maybe having more common exacerbations, maybe starting to have these conversations about what's important to people. I wanted to show you this quickly. I believe James is going to say a few words about this, but this is a palliative performance scale. So it's one of the diagnostic scoring tools that we use to help define when people are perhaps approaching a time when their care needs are going to increase, and maybe they're going to be approaching the end of life. So it's fairly self-explanatory. If you look through, you've got 100%, so someone's got full mobility, they're able to do normal activity and work, they're independent of all their normal activities of daily life, eating and drinking well, and there's no confusion, no cognitive impairment. And as you can see, as people's function changes over time, as you find that their mobility goes down, as maybe they're not able to work, or they're not able to do tasks around the home, and they start needing assistance with things like washing and dressing and things like that, you can see that palliative performance score starts dropping, and we start to see that they're needing more assistance. I won't go into any more depth in that because James will be having a little chat about that in a moment as well. So for me, looking at the challenges to diagnosing dying in non-malignant disease, I think one of the greatest ones is that uncertain disease trajectory. So we know, if we think back of other patients that we look after, your respiratory illnesses are absolute classic examples of these recurrent exacerbations. People could be bouncing back and forth to hospital, you know, having treatments. Maybe they go back to the baseline. Maybe they're not quite as well when they come out of hospital. But you start to notice over time those exacerbations get more and more frequent. The problem is often at a big part of their journey, they're going to keep going into hospital, and there are things that can be actively done to help get someone back to a good baseline. Over time, they're going to have less response to treatment. Maybe they'll have longer time in hospital. Maybe they'll start finding that their function is not as good when they come out, so that they start deconditioning. So actually what they need is starting to get assistance and get care packages in place to help support them. So that can be really hard for people because they can't get their head around the idea that actually, well, I went into hospital last time and I was much better when I came out. And now we're going in this time and I've come out and I'm nowhere near as good as I was the last time I came out of hospital. Now I'm needing help. My breathlessness is still dreadful. What is happening to me? And that's really hard, I think, for not only the person going through this, but the people around them to come to terms with. And they think they can struggle with trying to understand what's happening. With these kind of diseases, there can be a high risk of a sudden death. And that, again, that's very hard for people to wrap their heads around, especially when we're starting to have advanced care planning discussions and thinking about what someone would want as they become less well. Maybe they don't appreciate that actually there's a risk for this to happen. Like I've said on the previous slide, you know, there's often a very slow decline that can be quite prolonged, and people get very used to their loved ones being in their lives, and it is very hard for them to look around. You know, it always amazes me sometimes when you've got a son and a daughter, they're in their 80s themselves, and they look round at their mum, 106, I think is the eldest I've had, and well, why is she dying? But you know, it's wrapping their head around. They find it so hard. And although, yes, we all know we won't live forever, actually sitting down and actually facing that mortality can be really hard for people. We're not good at talking about death in this country, and it's something we're trying to get better at. As Fiona picked up on, people often have a lot of comorbidities, which can all be conflicting with each other. And some people can be exacerbating with one, which can sometimes knock another one off, which can make things very complicated and very challenging for people. And obviously, over time, older people, we generally know, get more frail over time. And sometimes there's no particular comorbidity that is causing the decline. Sometimes it is frailty. And there's a lovely quote, I can't remember who came up with it, I don't think it's Catherine Mannix, but she uses the lovely image of the paper boat in the water. And the paper boat can cope for long periods of time, but slowly it's soaking up that water, and in the end it is too delicate to be able to cope, and then that's when that person slowly deteriorates further, which I think is an imagery which actually can sometimes help people because they can imagine it. One of the other things that I think is very important to consider when we're looking at whether someone's coming towards the end of their life in non-malignant disease is a lot of the signs of dying are very indicative of potential reversible causes. One of the things I think is really important when I'm having conversations with people and I'm concerned that there may be a reversible cause, but whether that person is going to recover from this episode is actually being really honest with people and open and saying, I don't know which way this is going to go. And one of the phrases that I use is the possibility of someone approaching the end of life. And saying about the possibility and looking at the reversible cause, you know, your loved one has a chest infection, but they are very frail and they have been getting gradually less well over time. And we need to consider that there is a possibility that they may not survive this episode. It allows people to take stock and to think about what you're saying and to see that we are trying to look after their loved ones, but we're preparing them for the worst. So it's not a shock if things change. One of the things that obviously is harder, and I think we find that in ourselves in palliative care, is that it's often harder to have advanced care planning discussions with our patients with non-malignant disease. And I think that is partly because of their own experience of going through their illness and their own disease journey. They can sometimes live these disorders for 10, 20 years. And all of a sudden, someone's asking them what they want to get this well. Have they considered where they want to be when they're dying? And they don't want to consider it because they have always had it treated and bounced back. And they can find it, they can find it hard, and they can find it challenging to think about these things. And as we've touched on before, they're often less likely to be supported by a local community specialist palliative care team. Now, we don't need to know every patient out there in the community. You know, you guys do a fantastic job of supporting these people out there day to day. But we often find, like with the advanced care planning discussions, there's a lot of uncertainty and a lot of fear when someone's approaching the end of life. And there will be people that you feel actually our expertise is helpful. And sometimes broaching that with families is hard because sometimes you're trying to manage their expectations. And sometimes it can feel like they're being given up on, which is further from the case. You know, the reality is that sometimes they need additional help and support, and we can be there to help support them with that. But it can be difficult to know when to bring us in as well. And I think hopefully James and Fiona are going to touch on that in a little bit. So interestingly, the literature is not very good on giving us extra evidence on diagnosing dying. So I've recently done a dissertation on end of life, and I was looking into what the literature said, and I found very limited evidence. There is actually, I will send the link to Fiona, because there is a new paper that has just come out, a new systematic review looking at diagnosing dying at the end of life. You know what I mean. Identifying the clinical signs of dying. But the reality is the vast majority of studies are focused on people with cancer diagnoses. They're focused on acute settings, so that's hospitals or the inpatient palliative units around the UK and internationally. But there is very little data on what the differences are, if they are, between people dying with cancer and people dying with non-malignant disease. And I think a lot of that, the biggest differences we would probably notice is the timeframes. Now, there's an interesting study by Hu et al. Back from 2014. Now, again, this was looking at cancer. He was working in a couple of, he was working in an inpatient specialist unit, and they were looking at the commonly documented clinical signs of dying in people with cancer. So we're going to come to that. Did you want me to carry on with my bit? So he identified 10 common signs. So the early signs, so these were 7 days prior to death. This was the average onset. So it was that palliative performance score that I showed you earlier being 20% or less. So that's someone who's typically completely bedbound, needing full assistance for care, usually mouthfuls or sips of fluid at most. The RAS, so RAS, if you're not familiar with it, is the Richmond Agitation Sedation Score. I'll be honest with you, we don't use this in the community. I last used this in intensive care. So for us in the community, I don't think this is a relevant thing to be using. And then dysphagia and fluid liquids. The later signs, so these were within 7 days of death, were reduced urine output, apneic episodes, the good old death rattle, I hate that phrase. Respiration, mandibular movements, chain stroke breathing, peripheral cyanosis, and pulselessness of radial artery. These are all really heavily clinical signs that you will see if you're there with someone continuously giving care in an acute setting. And I don't find myself that these are particularly helpful in the community. I worked in an inpatient hospice for 3 years before joining City Hospice. And actually, even myself, there were a lot of these signs you know, we see other signs leading up to this, but these are very much, you know, in these last couple of days. If you've got any thoughts and your experiences of these, it'd be really interesting to see what you think. This I found was much more helpful. So this is from another study. Again, it was cancer related, but this was part of a focus group study conducted. There was three different wards that they where people were supported with the diagnosis of cancer. But what was interesting was this is coming from the nurses, and there's a lot more information there. We will make sure you've got access to these slides as well, because there's a lot on there. But it was really interesting getting that much more holistic look at how people are presenting. And what's interesting was maybe some of the other issues, such as psychological and the spiritual. I know from our own experience, we often find that people recognise that they're approaching the end of life. They will often say, I feel ready. If they've got elements of confusion, impaired cognition, we'll often find that loved ones are saying they've started seeing loved ones at their bedside, or they've started saying goodbye to people, which is really interesting. We often find people can get quite agitated and restless in those preceding days. And some of the other symptoms you'll hopefully be a bit more familiar with. So we'll find that they're pretty much staying in bed, completely bedbound. You may find that they're getting constipated, having problems passing urine, things like that, or maybe the complete opposite, and they're completely incontinent now. We'll usually find they're just having very, very reduced oral intake. So usually getting down to the point where it's just sips, just mouthfuls. They're now struggling with dysphagia. Maybe they're not able to manage their tablets anymore. There's a lot of symptoms that will increase as they approach the end of life. And if someone already suffers with pain, we'll find that their pain usually increases as they're approaching the end of life. But things like nausea and vomiting can sometimes increase as well. And respiratory symptoms. So we will see changes in breathing. So we will see things like increased breathing rates. We may see them feeling very breathless, getting distressed with breathlessness. Maybe those respiratory secretions that we try and manage. And that's really important. We can help manage some of those symptoms, especially the rapid breathing rates and the secretions. But it can be really intimidating when people are feeling breathless and anxious. And it is very important just to sit with these people and just give them that time to express those concerns. So yeah, it was interesting to see just how much came out from that one.
Can I suggest we pause there for a minute?
Yeah.
And go back to.
Hold on. Let me. Do you want me to? I can't go back.
Do you want to mute the computer?
Mute. Yeah.
Lovely. Thank you so much. I'm just going to pause at this point and maybe Katrina, just go back to your last slide with all the beautiful colours on it.
Hold on. Right.
We go. Just because I think at this point it's fascinating, I think, to hear the literature, and there are some very clever people doing very clever stuff out there. There's a very interesting and somewhat troubling, I have to say, being personal, but very interesting, really beautifully conducted research coming out of Liverpool around biochemical markers that indicate that death is approaching. And that just raises some interesting ethical issues about, would it suit everybody to know, for example? So there's a lot of work going on behind the scenes, but there's also a difference with our practical, on the ground, in somebody's house or in surgery. Actually, what are we seeing in front of us and what does it mean? And I'd like to bring in James now, because we've been doing quite a lot of work. James has been leading projects on quite a lot of work around the practical use of some of these tools, which of course arose from cancer, which is great, but actually they're talking about non-malignant disease. So I think now would be a good moment, James, to bring you in. And folks, do please feel free to add your thoughts on the chat about if there are some physical signs, if there are things that you find useful. James, I'm handing the baton over to you. Hopefully the microphone will work.
Hopefully I won't drop it. So have I got a bit of an echo? I'm gonna shut that one. Just 2 seconds, sorry. Sorry, we've been having some technical. Is that better? Yeah, lovely. So as you say, I think we've been having a look at, actually with a very good year 4 SSC student who's been looking at a project, because I think it's been, particularly of interest to see there isn't much information out there. We use things like the surprise question, which actually is probably as good as we've had in terms of practical applications of things to prognosticate. Because I think for me the stuff that, as you say, the research around biochemical markers and things is really interesting. How practical that is a different matter. And so for me, the practical, actually, if I'm seeing 4 or 5 people in a day and I need to use it there and then, something that tangible that people can take away. So one of the things that we've been looking at, or part of this project, was looking at a scoring tool that we've been using. So I did a thing as a registrar, looking at using the Palliative Prognostic Index as a relatively simple practical thing that we could use to look at people's prognoses. So I'm going to try and share my screen. Hopefully I'll be able to do that. There we go. Can you see that? Yeah, lovely. So this is actually the paper which we're going to try and submit, actually, as a
sorry, James, not quite. It was looking really good, but we've got a blank screen at the moment.
Can you see it now?
No, we can see your screen of all of us, which is very exciting, but I'm sure it's not what you want us to see.
No, it's nice, but it's right.
It's cool.
Let me window. I tell you what. Let me look at window. There we go. How about that?
Yes.
Yeah, lovely. See the technical stuff. So it's looking at. So this is the simple thing that we've been using for a number of years. So it's using something called the Palliative Prognostic Index. So that uses the Palliative Performance Scale, which Kat has touched upon. It looks complicated, but it's basically how much can you do functionally, how awake are you, and how much in sort of food and drink intake you have, which I think for most people, in terms of when you're seeing someone deteriorate, I don't think you have to be a medical professional to say that actually somebody is deteriorating. There are gut things, instincts in us as human beings that make us think, well, actually a person or animal or whoever actually looks really unwell. But it's taking those things and putting it into a scoring system, and then coupling this with sort of 4 other areas. One is oral intake, which actually comes into the Palliative Performance Scale, but that's one on its own. So that's an important marker. Whether they've got edema or not, whether they're breathless at rest, and whether there's evidence of delirium. And delirium is obviously different to cognitive impairment. So if you've got a dementia, that wouldn't be delirium in itself. If it's an acute confusion. You put all that together and you come up with a score out of 15. The higher your score, the shorter your prognosis. And but all of this information is in inpatient or hospital-based patients with cancer. So we were using it for everybody, and thinking, well, there isn't that much practical out there, that much else practical out there that we could use. So what we did was actually look at, and it's sad what I get excited about these days, but this I think is quite exciting research, because we looked actually at about over 2,400 patients under our care over 3 years, and we routinely did the Palliative Prognostic Index for everybody. All the other studies are looking at sort of 100, 150. we looked at not just cancer, we looked at it for cancer and for non-cancer. And if you combine the sensitivity, and specificity, which is essentially saying sensitivity is how many people the score predicts correctly that they're going to die within that specific time, and specificity is how many people who don't have that score it's correct. I know that makes no sense, but I always have to go back and look in a book. The better the percentage, the more accurate it is. And actually looking at our data for everybody, that's cancer and non-cancer, and looking at our data, about a third are non-cancer, it actually tallies up with other studies. But the difference between this and other studies which have been done is that this includes non-cancer and it's in the community. So it's two things separate to what other studies have done. And what we did, because you should never do this, you should never go into a study assuming you're going to know the answer, but I did, and I got it wrong, as I usually do. But I'd assumed that non-cancer, it wasn't going to predict very well, and cancer, it was going to predict better. Because thinking back to Kat's earlier slide, looking at the trajectories and the more uncertainty with non-cancer, I'd assumed that it wasn't going to be as good. But actually, it's pretty much the same as for cancer and non-cancer, which is actually reassuring that we're using it appropriately across. I mean, we didn't cut it down into each individual non-cancer diagnosis, but overall, cancer and non-cancer is similar, which kind of goes against my gut feeling, but actually it's robust data because this is nearly 2,500 patients. What it says and what we're probably going to publish, the findings are that if your Palliative prognostic index, looking back at this, if your Palliative prognostic index is over 6 in total, then your prognosis is predicted to be less than 3 weeks. If it's over 4, your prognosis is predicted to be to be 6 weeks or less. And if it's less than 4, it's more than 6 weeks. So, and it predicts it with relative accuracy. So I think it's quite exciting that we now have something, hopefully if this is published, we now have something which says that in the community and in non-malignant disease, it's as good as with cancer. But you've also, if you look, I mean, it's not infallible, it's not 100%. And I think that's a really important point, to think that, well, these things are useful, but you can't use them in isolation. You can't say, well, to a patient or a family, well, your Palliative prognostic index is 8, therefore you will be dead in 3 weeks. You use it to help guide you and help guide your discussion, and then it's up to you and using your communication skills to whoever you're talking to try and incorporate it into what ultimately then is still your gut feeling, because we're awful at prognostication. These are tools which can help, but I would caution people, even though I'm saying I'm excited about it, I would caution people about using something like this and nothing else. But yeah, sort of hot off the press, and hopefully something quite useful and quite interesting. I've seen there that I think, is it Sarah has said that weight loss is a good indicator. I mean, I think if you look at the Palliative prognostic index, actually reduced oral intake and makes up a part of that, and it also is part of the Palliative performance scale. So it makes sense that actually people would lose weight because they're eating less. And yeah, so I mean, any thoughts, any questions on that, any experience, positive or negative, with sort of prognostication scores? Because I'm not sort of wedded to this. It's not my baby. It's just because I realize they're not completely infallible.
And I think just while people are thinking, it's like we said at the beginning, and like in the comments so far, what it means to each of those individual patients that we see in their houses, in their care homes, in surgeries, will be different. And so it's part of this moving towards end of life, but actually our kind of skills in picking up how we use the tools and how we communicate and all of that, as always, will be unique and different for each person. And I was also interested, thank you, Sarah, for writing that bit about weight loss. I'm also fascinated by that because I think it is, for whatever reason, people's intake will go down. What can be difficult to predict is then what happens, but it is kind of one of those just early warning signs of things are changing. And so actually, okay, I don't know how long this is going to be, but things are changing, looks like they're changing. So what do we need to do to be prepared for whenever things are going to happen? I finding it really hard to believe that actually we're nearly at 2:45. So I'm going to make a suggestion. If you've got comments, questions, do add them in the chat. But actually, we've got a little bit more that Catriona needs to share to really help bring some of this together. So I'm going to suggest that we crack on with the last few slides. But please feel free to, as you have any thoughts or questions or reflections, please pop them in the chat. Thanks, Catriona. Thanks, James.
Thank you. That was really interesting. We use it, as James says, in our notes regularly. It's really interesting to see just how powerful a tool it's becoming. So I will try and whiz through this as quickly as I can, because I do appreciate the time. But like Fiona says, do pop any comments or questions into the chat. So care in the last days of life. So we're concerned, we've gone out to see someone and we're concerned there's a possibility that they may be approaching those last days of life. So when we're going out to see people and assessing them, then we do need to initially think about any reversible causes and what would they want with that. So are they someone that we're going to keep home? If we actually feel there's a high risk of them dying, should we be sending this person into hospital to have any reversible causes treated? Or is that a strong wish of theirs that they would want anything potentially treated in hospital? So that's where I've put at the very bottom there, remember our sensitive communication. And I know we've got a session on that coming up about having some of these difficult conversations. We want to have a little look at their medications and maybe try and rationalise as much as we can. If they're still swallowing, do we really want them taking 10, 20 tablets? If we can just try and limit to what will be the best to manage their symptoms going forward. So our focus should always really be about keeping someone's symptoms well controlled, about keeping them comfortable, and about exploring their wishes and about supporting them with that. We should make sure that there's a do not attempt cardiopulmonary resuscitation form in place. It should be really clear. We should have a conversation with the family and the person about why this form is being put in place if it's not already there. And it should be clear as well that this is just for when the heart stops naturally, because that person has come to the end of their life. That we wouldn't be restarting their heart artificially, either through compressions or through, using the pads. It doesn't stop anything else. If they want antibiotics to try and treat that chest infection, it doesn't stop that. It doesn't stop going into hospital. If we don't already know, we need to establish the preferred place of care and death. If the preferred place of death is home, we need to really make sure that this is achievable. There are certain circumstances at home where perhaps it's not. Maybe they've got an unsafe home environment. Maybe they don't have the right equipment in place and we're not going to get it there in time. Maybe there's challenging social conditions that may prevent them being able to stay at home if that's what their wish is. And it's really important to liaise with our community nurses, our district nurses, if they're known to the community specialist team, getting them involved, especially if achieving a place of death at home, if that's a desired outcome, and there's going to be challenges, and working closely together in a multidisciplinary team is so vital to help that happen. And obviously the community nurses can also help make sure they've got the equipment that they need in place. We need to look at their symptoms. We need to do a full symptom assessment and make sure we've got the medications in place to help keep people comfortable, and I will touch very briefly on that as well. And ideally, if we really consider them to be in the last days of life, then we do need to think about our anticipatory medications and the injectable forms of the medications, and make sure there's a drug chart in the house as well. It's worth noting as well, as someone who works in the out of hours service on the weekends, special notes going over to the out of hours service can really help prevent avoidable admissions to hospitals. You know, we can't access all of the notes, people's notes down in Cardiff Infirmary. We're very limited to the information that we can access. So actually, if you've completed a do not resuscitate form, if an advanced care plan form is in place, avoiding people going into hospital, you know, if we need to just send special notes to the out of hours to update them if anything, that will make that whole process much smoother for people. And we will touch very briefly on this as well. If we do feel someone's approaching the last days of life, then there's the All Wales Guidance Care Decisions for the Last Days of Life. So that's a document that replaced the Liverpool Care Pathway in Wales that we use to help support people at the end of their life. It's a really useful document. One of the problems has been in the past is the time it takes to complete, but I've got some information on that as well. So interestingly, symptom management needs generally, as a general rule of thumb, at end of life are going to be very similar with malignant disease. Most of our patients have some kind of pain. They often suffer with breathlessness, often as a side effect of their heart failure, renal failures, you know, things like that. They'll often suffer with nausea and vomiting. There'll often be levels of agitation and stress at the end of life, and certainly at the end of life we'll see people developing those audible secretions, which are often more distressing for the family and healthcare professionals than actually for the dying person, in all honesty. And just a little request generally from a healthcare professional to another, for requesting anticipatory medications and a drug chart. And we think in the future we may need a syringe driver. Please can we get a script forward for injection at the same time? It just means if we're getting a driver set up overnight, it just makes things a bit smoother for everyone. So I just wanted to touch on a few of the more common non-malignant diseases, and just think about some things we may need to think about. So the first was heart failure. It's one of the more common, it's in fact one of the most common causes of death across the UK. So common symptoms are usually breathlessness. We often find that increased respiratory secretions. They're often suffering from overload, these patients. They get intense fatigue. They also usually very commonly have nausea and constipation, which, you know, any of these symptoms on their own are very unpleasant, but all together people can really suffer when they're approaching the end of life. One of the recommendations is that we avoid stopping any heart failure medications unless they're no longer able to swallow. So if they can manage their diuretics, if they can manage things like their bisoprolol and things like that, it's really important when we're rationalising the medications that we don't stop those unless they're no longer able to manage them. One of the things that can sometimes help if we've got someone approaching end of life who's really struggling with fluid overload is sometimes we can give furosemide via syringe driver. There is a supportive heart failure team running across Cardiff, and it may be worth, if you've got someone with complex heart failure, you can refer them to this service as well. They do support patients in community. They can also liaise with us, so sometimes they'll have both the supportive heart failure team and the community specialist team involved as well. One of the things that we often come across in the community as well is when people have an ICD in place. So obviously that's the it's not just a pacemaker, it's going to shock people when that heart is going into the arrhythmias. Now, this can, if someone is not for resuscitation, we can get this this element of the device switched off. It is a referral through to the community cardiology team, and they are able to come to people's houses and get that switched off. So that is something that we do need to consider, and we do need to have conversations
with the dying person and the people important to them if they are identified as having an ICD in place. So do please have a think about that. We can get palliative oxygen. So this is something that the community palliative teams can't prescribe. We do need to go through the GPs to get this prescribed. But if you're ever unsure about how to request this, there's information on the Cardiff University intranet, which is really helpful. They've also got the forms there. You can also call Bayswater as well, and they're really helpful in guiding people into getting these things in place. And it is a case of, if we're asking for palliative oxygen to manage someone's sensation of breathlessness with low oxygen levels, it can be really helpful. They can often get it in place within 24 hours. So that is something that can be really beneficial for someone with heart failure. Generally, we'd avoid cyclazine just due to risk of arrhythmias, and same with hyoscine hydrobromide. It can be used, but we tend to be more cautious with it. With end-stage renal failure, one of the things we really need to think about is the elimination of the medications that we're using. There's some great information out there from the Renal Society and places like that. But generally, opioids, we start looking at reducing the doses. So if you've got someone who's on morphine and they've got a low EGFR, if you've got time and we've got time to get things in place, I would ideally swap over to oxycodone once someone's EGFR is in the 30s or 40s, to be honest. If we don't have time to do that, if that person's dying and they've got morphine there and we just need to keep them comfortable and manage sensations of breathlessness or pain, then we need to significantly reduce the amount of morphine that we're giving people. And there's clear information on this in the renal guidelines, but there's also information on the care decisions as well. If someone's EGFR is particularly low, then we may think about just using subcut injections rather than continuous infusions. What we'll generally find is the drug won't be eliminated for much longer periods of time. So sometimes we can find that's enough to manage people's symptoms. Obviously, if someone's receiving hemodialysis and then that is stopped because they're no longer fit to attend, we often find people deteriorate extremely rapidly following cessation. So if we know we've got a patient who is going to be, who's currently on hemodialysis and they're going to be stopping, we need to get things in place straight away. So it's always worth thinking about that. And I've popped a little comment there about uremic itch. So if you've got someone who isn't clearing their urea because of their end-stage renal failure, they can often get a global itch. And one of the ways that we can manage that without using additional medications is a menthol cream. One of the tips I usually give to people is keep it in the fridge. So it's extra cold as well because it soothes those overexcited nerves as well. And then with end-stage renal failure, it's one of those particularly unpredictable diseases where someone can honestly, you can walk in and you think, ye gads, this person's dying, throw everything at them. You go in the next day and they're having a chicken dinner. And it's really challenging for loved ones as well. And people can live with a low EGFR for a long time. So we do need to just not raise people's expectations as to what's happening. And I think, again, talking about the possibility of someone approaching the end of life is really important, particularly in end-stage renal failure, because it is one of the more unpredictable diseases. Dementia, so we touched on how prolonged a slow deterioration can be, and it's amazing, you know, James has talked about it, we've all touched on that fact of the low oral intake. It's really amazing how little people with dementia can eat over a long period of time and still be with us, and that's really difficult for loved ones. One of the things as well I find particularly interesting in managing people with dementia, supporting them, is actually looking at those reversible causes, particularly constipation. I've had a number of patients where they've clinically looked like they could be dying. You explore their bowel history, discover they haven't opened their bowels for 10 to 12 days, get their bowels going again, and they return to baseline. And I find that more in patients with dementia than I do in a lot of my other patients. So it is, again, it's one of those things that's really important to rule out when we're looking at that person. One of the things as well that's really helpful to look at is, because people with dementia or other cognitive impairments aren't always able to express when they have pain, we may need to rely on carers able to give their own information and own history, particularly non-verbal behaviour, maybe grimacing, maybe the frowning, maybe some behaviour that's particular to that person of how they express themselves when they're in pain as well, which the people who are around them would be much more familiar with. So it's really important to take that account, because there may be some underlying pain that's not being recognised. And patients with dementia are more likely, or anyone with reduced cognitive impairment, are more likely to suffer with hallucinations at the end of life. They may be on antipsychotic medications leading up to this point, but if we know they're high risk of delirium and hallucinations, we may want to get some haloperidol subcut for that end of life phase to help maybe manage some of those symptoms so that they're not distressed. I do want to go briefly about M&D. I am watching the time there, I do apologise. So M&D is a particularly challenging one to look after. We've often got a younger population that we're caring for with this. One of the most powerful tools that we can use to help support our patients with this is advanced care planning, and we should be doing this long before they approach the end of life, so that people with M&D can keep some control over their life. One of the big conversations they want to have if they're already on non-invasive ventilation is whether or not it would be discontinued at the end of life. And people often have really strong views, which is worth documenting. And the same with PEG feed. So it's really important, if someone's receiving their nutrition and fluids via a PEG, that when they're coming towards the end of their life, that we have discussions about reducing the feed. And how I have these conversations is about raising with families, actually, if someone's approaching the end of life, if we weren't artificially feeding them, we would see a pattern of, over a short period of time, or maybe days to short weeks, we would see people having much less to eat or drink as their body started to decline and as they didn't want it anymore. And actually what we should then be doing is emulating that. So by slowly reducing the feed to manage people's symptoms of nausea, of vomiting, of abdominal cramping and of bloating, we can then gradually reduce the feed based on that person's symptoms. And I think that's a really important thing to bear in mind, is actually when you're discussing with the family and the dying person, if they're able to engage in the conversations, reducing the feed should be based on that person's symptoms. You'll find the family will be much more willing to be on board the conversation, and they will actually, it will give them that sense of control over what's happening as well. And I've had several experiences of this, particular one last year where it worked so beautifully. We talked about it several times. We went through, the feed generally went down whenever he developed unpleasant symptoms. It never went back up. And it was really lovely to see that actually both the patient and his wife were really empowered during the whole process and got to keep some element of control. Just a little brief point as well, you know, M&D patients will often suffer with either hypersalivation or really thickened fluids, and we need to help manage those secretions for them, because that can be very distressing at end of life. I've just, again, briefly, just a little bit on Parkinson's disease. So as I'm sure you're all aware, we're wanting to avoid medications that are going to affect the dopamine levels. So particularly at end of life, we don't want to be prescribing haloperidol, metoclopramide, levothyroxine. Now, if you've got someone on things like Madapar or Sinemet, there is actually a fantastic tool on the Parkinson's website, and I've left the link there for you. It is one of the dose calculators. You put in the dose that your patient's currently taking and the frequency, and it will tell you and what dose rotagotine patch should be swapped to. The latest teaching from the Parkinson's Society is actually to use a calculator, and then if it's possible to take a step down. So if they suggest 2 milligrams, go down to 1 milligram if it is possible. And again, that's just to make sure that they're not suffering then unpleasant side effects or withdrawal from their Parkinson's medications. So we've got a couple more slides left.
You were mentioning about the care decisions. You have something to say about an update. So in the interest of time, what about just talking about that one? So skip on for 3 slides. That would be fab.
So I just ever so briefly then want to come into the Wales guidance care decisions for the last days in life. So this document is available on the NHS Wales Executive website. It's a really useful tool. The actual guidance that we put in place is only 4 pages. Now, version 11, which is still currently out, says that the lead clinicians, so GPs, doctors, should be completing pages 1, 2, and 4, and the nurse should complete 3, with flexibility depending on availability. With version 12, so we'd raised our concerns with the End of Life Care Board about actually how difficult this is in the community, with GP workloads and the fact that you may not always know these patients as well. Do you have time to do all of this? And what they've actually said, there's a lot more flexibility in completing these pages. So going forward, version 12 should be out in the next month or 2, fingers crossed. But the idea behind it is, as long as the lead clinician, so in your cases it would be yourselves as GPs, as long as you're engaged in the review in some way, so either the nurse is reporting to you, you're doing a telephone consult or a video consult, if you're happy to countersign it, then it is okay for the nurse to complete the main guidance. I'm hoping that will mean we'll be able to use this for much more. It's based on the 5 priorities for care of the dying person. And it's really helpful to document those difficult and challenging conversations that we're having with the dying person and the people important to them. It's also got aspects about nutrition and things like that that we've just talked about with the PEG. And if we can start using it a little bit more across Wales, I think it'd be really helpful. So it'd be interesting. I know as City Hospice, we're looking to unroll it a bit more. So it'd be really interesting to get your feedback as we get on with that. I think that's really all I want to say about that. My previous slides on symptom management are all directly taken from document E, symptom control guidance, which is part of the All Wales guidance care decisions for the last days in life. So obviously you will get access to these slides, but have a little look at that flow chart as well, because it's a really useful document, I think.
Fiona, thank you. Do you want to press the mute button on your thing so we haven't got a thing? Lovely, thank you so much. I put the link, I'm sure you know the link, I'm sure you know it all, but the link is there in the chat, and I just put a link to Bayswater as well, Bayswater as well, the oxygen. Again, I'm sure you know all of this, but just in case, it's helpful to have it as part of the same thing. I think our final slide was just, and I'm aware of time, and everybody will need to get on and do their next thing on the list. But actually, I think going back to where we started with this session, one of the challenges around end-of-life care, diagnosing dying, the start of that end-of-life trajectory, if you like, in people who haven't got cancer, is so often it isn't just one team, and out in the community, we're often kind of can be slightly bewildered by how many teams are there actually involved. Is there a Parkinson's team and a heart failure team and a diabetes team? And so therefore, when I'm thinking about end of life and diagnosing dying, which of those teams will be important to liaise with, but possibly as well, what has that team got to offer to that patient, and has that changed over time? And again, I think there's slight differences with patients, isn't there, because people have different relationships with the specialist teams that might have overseen their care. Some are very involved, some are more peripheral, and so I think one of our other challenges is just in navigating as to who's doing what, who can add things, and from our point of view as the community specialist palliative care team, where can we help the most? What can we add to the care that is already being given to that patient? And one of the things I think that we wanted just to highlight is that just occasionally you may refer to us, you may hear of our involvement, and then suddenly hear that we're discharging people. Now, when I started in palliative care 30 years ago, it was unheard of to discharge people from the palliative care team. You were under the palliative care team until you died. Well, wonderfully now, that isn't the case. Because palliative care, we can be a resource for people who haven't got cancer, which is fantastic. It's widening access. But also people are living longer, but they're living longer with more complexity. So don't be alarmed if you refer to your community palliative care team wherever you work, whether it's ourselves or a different team where you are. There may be particular needs that have prompted that referral, which is fantastic, and the palliative care team will review, we'll see where we can support. But if those needs then have been met and the person is settled and they're on one of those trajectories that's a little bit slower, but actually everything's in place, advanced care planning's been done, conversations have been had, the palliative care team may step back just because there will be others to fill that place for that patient until or unless we're needed again. So it's just, again, encouraging that flexibility, which I know that locally to us, I think we've got the balance just about right, but it's just, I think it's useful because this is a webinar that's going to be available on the CPD channel. I think it's relevant just to say that sometimes people have particular needs at particular points, and particularly with non-malignant conditions, and so often there's more than one. Sometimes it's just terribly helpful to throw your ideas around and to chat something through and to have extra pair of eyes and ears helping to sort of sift through the competing priorities and compromises. I'm conscious of time. Before we stop the recording, I'm just going to sort of do the general things and just call in for James just for a minute. James, is there anything else that you want to add to Catriona's or to the sort of our final session? And as James is talking, do please fill the evaluation form in and B, have a think. James, anything you want to add?
I think it's probably in the first instance is I think it's a bit of a there's a bit of a false kind of division between cancer and non-cancer in terms of thinking about, I know we have to do it, but it's thinking about actually most of what we do with someone who's approaching the end of life, it doesn't really matter what their illness is. How that illness affects them and how their trajectory looks will differ, but actually the principles, I think, are all the same. And so if we boil it back down to basics about what are we trying to do for this person, I mean, we're looking after someone holistically and thinking about advanced care planning. That is the same whether it's cancer or non-cancer. It's just the non-cancer has got some nuances different to cancer that we need to take into account, especially in that advanced care planning arm, because if we think, well, I know you're going to get another exacerbation of your COPD, we need to specifically talk about that. What do you want to happen if you were unwell? Let's do that now. But that's making it as an individual, so not seeing someone necessarily as the illness, but that illness is part of them as an individual. So that's sort of the first thing. And the second thing I think about prognostication is, for me, the big question is not right, how long do I think? It's why is someone asking that question in the first place? Because it may well be that somebody, that number one, sometimes it can be a knee-jerk reaction. Kind of, you have to ask how long because that's what people do. And then sometimes people regret asking it. But also, it may well be just practical things that people have to do, or well, actually, if I've only got potentially 3 months to live, then I need to do my will, I need to get my family, I need to say goodbye to people. So sometimes it's that. And so asking the why is important, because sometimes we can help with some of the things that people want to do. But also I think the other thing I would say in terms of prognostication and advanced care planning, especially in non-malignant illness, I think showing a bit of being honest and saying I don't know, I think is important, and people I think respect that when you say, look, we're not very good at this. This is my gut feeling. I think people appreciate that rather than uncertainty, which we don't have. But then I think when we're doing that is being honest, is being empathetically honest. If we think time is short, we think time is short. We need to communicate that in an empathetic way. But for the vast majority of people, when you see that person's dying process and the bereavement afterwards, the initial almost shock of, wow, we may only be talking a couple of weeks, that initial shock, the benefit of everything that happens after that in terms of people's understanding and expectation massively outweighs that initial shock, if that makes sense.
Thank you. I think that's so important, and I think that raises another, just that thing which I'm sure will be touched on a little bit next week, which is about that actually, of course, our care is focused on the person who is dying. Of course it is. The family is an integral part of that, or the carers are an integral part of that, but actually how this bit is managed, that's what families will remember, and that will then affect their own grieving and their health seeking, their general health and mental health after the person has died. So it is so important to get that right. I'm going to say thank you so much to everybody. I'm going to suggest to Charlotte that thank you for putting the slide on. I think we could probably stop the recording now. But